Certificate of Need Task Force. I will ask the secretary to please call the roll.
Senator Byrd. Present. Senator Givens. Senator Meredith.
Here.
Senator Schickel.
Present.
Representative Burke. Representative Elliott.
Present.
Representative Proctor.
Present.
Representative Witten.
Present.
Co-Chair Weber.
Here.
Chairman Douglas.
Present. Again, we do have a quorum. Again, I do want to thank everyone for being here this morning. First of all, before we get started, I'd like to have a motion for approval of the meetings from July 17. We have a motion. Do I hear a second? Second. Thank you so very much. The minutes from July 17 have all those in favor, please say aye.
Aye.
All those nay? No? All right. The minutes are approved with that. Before we get started, I will say some things that I generally say. The welcome is just the first part. When I have presenters come in front of this particular committee, I want to make sure that everyone is able to understand what it is that you're talking about. So I respectfully request that abbreviations not be used. You may understand what those abbreviations are, and many of us on the committee may understand what those abbreviations are, but I assure you that most of the people who are listening in the auditory and the visual media have absolutely positively no idea what you're talking about. And once they get behind, they will not understand the subject. And as your chairman, and as their chairman, I really want our public to be able to understand what it is that we are talking about when we're doing the public's business. So I respectfully request that we not use those. I also, after presentation, will allow questions. We prefer not to have questions during the presentation unless the committee member really feels it needs to be asked. Then they can have approval for that. But otherwise, we'll wait till the end of your presentation to ask questions. One of the things I also would respectfully ask is that during the answer of those of those questions, you have about 2 to 2.5 minutes. And yes, I will be timing. If you can't answer it in that amount of time, at least in the medical space, one of the things I've learned is you probably don't know the answer. And so we don't want to waste each other's time. I say that in a very respectful way, and hope that we can honor each other's time here. So with that being said, I would ask our first presenters to step to the podium or step up to the desk. Please identify yourselves for the record.
Oh, there we go. Good morning. My name is Melissa Faust. I am the State Affairs Director for Americans for Prosperity, and I'm here today representing them on this issue.
Before we get started, Ms. Faust,
Yes,
would you
please.
raise your right hand, please?
Certainly.
Do you solemnly swear to tell the whole truth and nothing but the truth?
I do.
Thank you very much. Proceed.
Absolutely. Thank you, Mr. Chair, and thank you, members of this task force, for the opportunity to speak. As mentioned, my name is Melissa Faust, and I'm here today representing Americans for Prosperity. AFP Kentucky partners with hundreds of grassroots advocates across the state to inform and influence public policy matters that are close to heart for liberty-minded Kentuckians. One issue that we have been working on as an organization for over a decade now is Certificate of Need, which is why I'm so pleased to be here today to talk to you all about our perspective on this important issue. It is timely, necessary, and laudable that this committee has taken on the work of evaluating the state Certificate of Need laws and their impact on your healthcare marketplace. No doubt, this week and in the coming months, you will hear from economists, hospital finance experts, and administrators, providers, patient advocates, and lawyers who have litigated on Certificate of Need issues. So I will stick to the perspective that I think AFP can best provide, which is insights we've gained from working with key stakeholders on Certificate of Need repeals and significant reforms across the country.
Excuse me, Ms. Faust.
Yes.
Unfortunately, I am painfully objective. I really would prefer that American for Prosperity be said? And,
Oh,
and not
certainly,
use the
certainly.
abbreviations?
No problem.
I apologize.
No, please.
Thank you very much.
Thank
Proceed.
you so much. So I will stick to the perspective I think Americans for Prosperity can best provide, which is the insights we've gained from working with key stakeholders on Certificate of Need repeals and significant reforms across the country, quite literally from Florida to Alaska. With that said, first and foremost, why are we even involved in advocacy on what many might view as kind of an esoteric healthcare regulation? Well, quite simply, we believe in order for everyday Kentuckians to be able to attain their version of the American dream, they need access to a healthcare system that is patient-centered and market-driven. I apologize, my tablet is getting kind of messed up here. When patients have true purchasing power and providers are unleashed to do the work they were trained for and are so passionate about doing, market forces are incredibly effective at balancing the desire for affordability with the need for quality, access, true choices, and the kind of innovation in treatment and cures that is the hallmark of the American healthcare system. And that's where Certificate of Need comes in. In a misguided attempt to control rising healthcare costs, the federal government required states to put in these anti-competitive measures. The theory was this: when healthcare facilities are in the same geographic regions and competing for the same patients, they will buy the latest gadgets, build the fanciest facilities, and do many costly things to try and grab the attention of consumers, all while passing along the buck for these bells and whistles to patients and their insurers, thereby driving up the cost of care. They also figured that by limiting competition, they could create a cross-subsidization effect that would help pay for indigent care. Cross-subsidization is a wonky term, but it basically means if heavily insured and or self-insured folks have no other option but to go to the same facility as uninsured or underinsured folks who cannot pay the full price of care, the rate that the facility can charge their better insured patients can help cover the cost of care for those who can't pay the full rate, allowing facilities to serve these patients while still staying out of the red. On paper, this sounds nice, and I'm sure that you've heard from a few incumbent facilities in or around your district who maintain that Certificate of Need does indeed perform these functions. But here's the truth of the matter. Decades of research does not find significant systemic effects that validate this claim. And what's more, from a purely anecdotal perspective, we've been directly involved in Certificate of Need repeals and significant reforms in Montana, Florida, Tennessee, North Carolina, and most recently South Carolina. And the sky hasn't fallen in those places. We've seen more capital investment, especially in suburban areas, but across the board, and hospitals have not been failing at any faster rate than they were before the laws were changed. And for what it's worth, the federal government realized that Certificate of Need did not have the intended effect. They reversed course, but for a majority of states, it was already too late. Incumbent facilities were not eager to give up their new competitor's veto and have fought tooth and nail to preserve Certificate of Need laws ever since. The Federal Trade Commission, throughout multiple successive administrations, both Democrat and Republican, has begged states to stop engaging in this anti-competitive practice. It's been really hard working on this issue. Most people don't even know that Certificate of Need laws exist. They know that they lack options. They know that something is wrong when they get sent to a hospital further away from their home because the one nearby was full. They can feel it when management at facilities they're seeking treatment from don't seem too worried about patient satisfaction with their own care. When a Virginia mom lost her baby because the hospital where her child was born lacked an incubator, she didn't find out until later that her hospital had applied years before to purchase incubators, only to have another hospital further away successfully argue that they had incubators and a neonatal intensive care unit. So it was unnecessary for that hospital to build a neonatal intensive care unit. The Certificate of Provider Need Board in Virginia agreed, and families suffered. When a doctor in Georgia wanted to start providing a less invasive version of colon screenings using new innovative technology, the hospital nearby argued that they provide old-school colonoscopies that are sufficient. The Certificate of Need Board agreed. Never mind that old school colonoscopies require more time off work for patients, more discomfort in preparation for the procedure, and more risk to the patient, which is always the case when you choose a more invasive procedure over a less invasive one. Patient convenience, comfort, and time away from their other activities were not considered as part of the Certificate of Need Board's decision-making process, and that's unacceptable. When a healthcare company asserted there was a need to build an additional hospital facility in South Carolina, its competitor objected. These two companies were tied up in litigation for a decade before the decision was made that yes, there was a need for another hospital facility. By the time the state was able to make that decision over the objections of a very litigious incumbent facility, the people of South Carolina went 10 years without additional access to additional healthcare capacity that the state finally decided had been necessary all along. These are just a few of the stories we've learned of so many others over the years. I personally started lobbying on Certificate of Need repeal for Americans for Prosperity 9 years ago. When I first started, I, like most people, had never heard of it. And it was only once I learned about what it was and was able to start looking at what facilities, equipment, and types of treatment my state Certificate of Need Board had denied that I started to see the fingerprints of Certificate of Need on some of the issues I and my family had dealt with in accessing timely local care. Every year I work on this issue, I hear more stories. I see more research get done, and I only become more and more convinced that Certificate of Need laws do not serve their purpose. At best, they don't do what they were designed for, and at worst, they actually hurt people. In a review of 128 papers that tested the effects of Certificate of Need laws, 89% of the research tests conducted showed neutral to negative effects as an outcome of Certificate of Need laws, and those negative effects are 500% more common than the neutral results. This literature review was produced recently by the Institute for Justice, and we're happy to provide copies of that to any of your offices. My sister organization, Americans for Prosperity Foundation, put out a report called Permission to Care, which details many of the individual stories I just shared. I know some of y'all have already read our report, but I would be happy to make sure that anyone else who would like to give it a read is able to. I have no doubt that the folks who grant certificates of need in states still have these laws are doing their best. But the fact of the matter is, no one has a crystal ball. States with Certificate of Need laws can only ever play catch-up to their community's healthcare needs. No matter how sophisticated your methodology is for deciding what types of facilities, equipment, and treatments are necessary, it will never be accurate enough to predict future needs. We learned this during COVID. When successive waves of the virus hit different states at different times, many states' healthcare facilities were strained to their limits and beyond. For states without Certificate of Need laws, hospitals were able to move faster in adding beds and converting, say, surgical recovery beds into additional infectious disease wards. In most Certificate of Need states, thankfully, governors realized the issue and waived the rules for a time. Unfortunately, even with the rules waived, states with Certificate of Need laws were 27% more likely to run out of hospital beds during those COVID surges. We might be tempted to think this was a unique situation, but unanticipated needs come along all of the time. Some states' populations grow faster than expected. Many didn't see the opioid epidemic coming and the need for additional substance abuse recovery treatment options. Breast cancer and colon cancer incidence is on the rise in 30 to 39-year-olds, prompting discussion that we may need to start regular screenings for these diseases sooner in life, meaning we need more capacity, more equipment to run these tests. Who knows what other challenges we'll face with an aging population. Take Kentucky specifically. You'll probably hear more about this story when the Institute for Justice provides comments during the next meeting, but a sizable Nepali-speaking community has grown in the Louisville area. A Nepalese immigrant, Dipendra Tiwari, and his business partner, Kishore Subkatka, attempted to open a small home health agency to serve this community, specifically geared towards their cultural needs, to include speaking their language. Their application was rejected when Baptist Health objected, saying there was sufficient care in the region. The Cabinet for Health and Family Services agreed, based on a rigid formula that did not take into account the fact that Baptists could not provide the same level of culturally appropriate care. It is not possible for any group, no matter how well informed, to be able to say with confidence what level of care, healthcare provision is or isn't adequate. And it becomes even less accurate of a prediction when incumbent businesses are given the power to chime in on whether or not there would be competitors or necessary. Incumbent facilities often wring their hands about boutique providers coming in, drawing off wealthier, healthier patients, and leaving critical access hospitals that are already in a precarious financial situation with the sickest patients that are the least likely to pay. It's a bleak picture, to be sure. We can look at this concern from a couple angles. First off, as I've already mentioned, research shows that we don't see a big subsidization effect with more uncompensated care being provided when more fully insured patients come to a facility and pay full freight. Secondly, this is a boogeyman that we hear about a lot that just doesn't seem to come to pass. Now, certainly you get your occasional facility that only accepts direct payment, not third-party payers, but these are few and far between. A plurality of Americans are on government health plans, be it Medicaid, Medicare, TRICARE, other government employee plans. And so most facilities accept most of these payers. Any facility accepting Medicare and that has an emergency department is required to stabilize every person that comes through the door, regardless of ability to pay. And in my experience, every single provider I've talked to who runs a surgery center or any other type of non-emergency facility provides a significant amount of uncompensated care. I think of an outpatient surgery center in North Florida whose doctors provide needed procedures to the inmates at the local women's prison, free of charge or at very low cost to the state, well below market rate. They weren't required to provide that care, and they were doing it long before Florida changed its laws to give them the ability to grow their facility. Finally, as I also mentioned before, patient comfort, convenience, and outcomes matter. Infection rates are lower, and there are fewer complications when patients receive elective surgeries at dedicated surgery centers rather than hospital facilities that are also treating trauma cases and infectious diseases. Do we limit some patients from accessing care in a venue that provides them with a better outcome as a means of providing financial support to a critical access hospital? This is a backwards way of trying to ensure access to quality care options for everyone. The data back up our experiences with Certificate of Need laws. States without Certificate of Need laws have more hospital beds per capita, including in rural areas, and costs for patient care are lower across the board. And very rural states with no Certificate of Need laws, Colorado, Idaho, Utah, Wyoming, have had 0 hospital closures in rural areas since at least 2005. None of this is to say that there are not real challenges with hospital financial viability. There is absolutely a real struggle in some places to keep the lights on, and it is a matter that this body should be treating with the utmost gravity. However, Certificate of Need is not the appropriate vehicle through which to address these challenges, and in many cases, it is doing more harm than good. It is my sincere hope that this committee thoroughly considers these points along with all of the other excellent information you have received and will continue to receive from stakeholders across this issue. Thank you very much for your time, and I'll be happy to answer any questions.
Thank you so very much for that wonderful presentation and for the conciseness of the presentation. What I'd like to do is I would like to open this up to questions from committee members if you are
Certainly.
ready. First, we have Senator Berg.
Thank you, Mr. Chairman. And if it's okay, I have 2 questions.
Proceed.
The first is, when you say you've talked to the key stakeholders throughout the state, do we have a list of those people? Who did you address this with before we brought this forward? And then, so my first question is, who are the key stakeholders in the state to whom you refer?
Mr. Chair? All right. Okay. Great. So the key stakeholders I refer to, and when I made that reference, I meant across states. We frequently work with everybody. So typically the groups that we reach out to, and to my knowledge we have for the most part in Kentucky as well, is the State's Medical Association, obviously as
The
representatives. Mhm. Yes. So we've met with them, and we do that across states. Yes.
Did you get an answer from them as to what their preference was on this issue?
So we're still having conversations with them. Our understanding is that they're not super active on this issue at this time, but their general stance on certificate of need laws is that they're not
Because they don't
probably the
apply to
best.
primary care. They don't apply to us as physicians. Certificate of need in Kentucky does not affect individual physicians. It has nothing to do with our practices. So my understanding with the KMA, and I'm sorry to put words in your mouth, they do not have a stance on this issue. It is not anything that they particularly think will impact them. So besides the KMA, who else did you talk to?
Well, we certainly talked to the facilities themselves. We talked to individual providers. We talked to individual community advocates.
To save time, because we are short, can you give me a list, please, of the stakeholders throughout the state that you talked to in person before this whole committee was set up? I would like that list.
Certainly,
So I
you
can
can-
go back to them and understand exactly what their concerns are. My second question, if I may, sir. You were talking about an individual physician that had a less invasive way of screening for colon cancer that was stopped because a facility performed colonoscopies. I can only assume that you're talking about Cologuard. What is the less invasive way of screening for colon cancer that your physician was wanting to do that was not allowed to be done because colonoscopies were being performed at the hospital? It's two different worlds in my mind. I don't understand the overlap. Can you explain that to me, please?
Certainly. This was 6 years ago. It was in 2017 in Georgia.
Kentucky?
In Georgia.
In Georgia.
As I mentioned, yes. in
Under
the
different
presentation, it was in
CON
Georgia.
laws?
Correct.
Okay, so that would not apply here in the state of Kentucky?
Well, certainly as we heard the example for the home health care agencies, when we have when proposals for home health care agencies,
Okay.
ambulatory surgical
But
centers,
as far
a lot of
as-
times hospital facilities will object to those individual
Okay.
non-hospital facilities.
And I'm apologize. I don't mean to speak over you. I'm sorry. I'm not a nice person sometimes. I know it. Keep going. He's holding my hand to make sure that I. Right. Okay. So this issue, was it Cologuard that you're talking about?
I'm actually not sure. I'd have to
So
ask
you're
the
not even
physician.
aware of what the underlying medical situation was?
Well, I am aware and talked directly to the doctor about what he was that he
Okay,
was
I'm
trying
just
to
going to
build
make a
facility.
statement that I don't think that would apply in Kentucky, because first of all, CONs don't apply to physicians in Kentucky. Second of all, any physician in this state that wants to offer Cologuard to their patients in their offices is more than free to do so. And I do not understand any hospital that would say no because we're doing colonoscopies. You
He
do
wanted
the
to build a
colonoscopies
facility to do
after
that.
the Cologuard. So it's just from a medical perspective, ma'am, your argument is not making sense. I think you need to tailor it to this state a little more. So thank you.
Thank you, Senator Berg. I'd like to move on, but one thing I would like to clarify, and again, since they've given me this nice little wooden gavel, you'll hear me keep talking about it. Definitions matter. Though the certificate of need may not apply to physicians, the argument that the certificate of needs do not affect physicians doesn't hold water. I just want to clarify that. We are here on a fact-finding mission, and I want to stick with the facts. With that being said, Senator Meredith has a question or three.
Possibly four, Mr. Chair. But first, I'd like to respectfully request that Senator Schickel come up here and hold my hand. Thank you. I represent a rural district, 5 counties, 2 critical access hospitals, 1 general acute care hospital. And I would hope that you would acknowledge that for rural hospitals, the majority of our payer mix is Medicare and Medicaid. And with that, they do not cover the full cost of care. In fact, Medicare is about 80% of the cost, not charges, cost, and Medicaid is significantly less than that. Not a very good business model to work from when you're going to lose money on every patient that you see. So I would ask you, then how does a hospital stay in business with that type of payer mix and that type of payer dynamic?
Thank you, Senator, for that question. And I do believe that I addressed that in the body of my testimony, but just to be entirely
I know
clear.
that you did. I just want some clarification so we're both on the same page. with regard to
Absolutely,
this.
absolutely, certainly. So yes, as I mentioned, hospital finances, especially in rural areas, it's a tough mix of payers, right? What certificate of need offers by way of a solution to that is to say we won't allow any other facilities.
That's
and
not
then
the
that
question
way,
I'm asking you. I'm asking you, how does a hospital survive when the majority of their patients do not even receive the total cost to provide that service? How do they survive?
Well, Senator, I definitely really appreciate that question, but this is a meeting on certificate of need. So
And
the
this
question would be
this is germane to this. very much
whether or
germane
not
to this.
certificate of need does anything to help improve those finances.
It does, though. That's the point I'm trying to make. So I explained to you since you're not going to answer my question. Again, majority of the patients you lose money on.
Certainly.
How do you make a profit, any profit at all? You have to have a commercial pay base of some semblance.
Certainly.
You have to have. And it's a very small percentage of your patient population.
Certainly.
If that percentage is diluted, particularly in rural communities, then where's the profit going to come from to survive? Now, I'll tell you, we're talking about theory, then we're talking about practical application. I'll give you practical application. If certificate of need disappears in Kentucky, for rural hospitals, what this means, I'll speak specifically to mine, what we'll see in my community is 26,000, service about 100,000. We'll see probably a freestanding surgery center that will only see commercial pay patients because it's usually from a for-profit venture. They're not going to see patients that can't afford to subsidize. You're going to see a freestanding imaging center, and both those services are about the only profit centers left for small rural hospitals. So you've lost two major revenue streams for these hospitals. How can you expect them to survive? Population's not growing, pretty stable, so you're diluting the patient base. Means you're taking revenue away from those hospitals unless you're doing a projection that rural communities don't deserve health care. You got to understand that with Kentucky right now, with 1.7 million people on Medicaid, it's placing a tremendous financial burden on all hospitals, but particularly rural communities. Another scenario I give you, as we open this up for other healthcare providers, there's going to be a staffing issue. And already we're 22% vacancy within registered nurses alone. In rural Kentucky, even though we represent 40% of the population, only 17% of the primary care physicians are there. So with a limited labor pool, that's going to increase the cost of labor, going to make it more difficult for rural communities to recruit and retain providers. So how can you say it's not going to negatively impact rural hospitals and rural communities? How can you say that?
I have not said that it wouldn't negatively impact rural hospitals. What I'm saying is that the literature and the experiences of other states show us that the express scale and scope of the impact is less than what is being stated. And furthermore, I do believe that folks living in rural communities deserve access to quality health care. A surgical center is going to offer them better outcomes than a hospital. There's nothing saying that a hospital association, a hospital administration can't build a ambulatory surgical center, and that could be part of their mix of businesses and investments that help them bring money in the door. But ultimately, that's a business question that they themselves have to answer. It doesn't come down to whether or not the state has a prevailing interest in regulating the industry in this way.
It should do. I acknowledge that for a lot of rural communities, it has a monopoly on health care, and justifiably so. If they're not there, who's going to provide the ER services? Who's going to provide those services that really don't generate any kind of revenue whatsoever? My small rural hospital is one of the last in Kentucky to provide obstetrical services. Why doesn't every rural hospital offer obstetrical services? Because you can't recruit providers, you can't afford the malpractice insurance, you can't afford the risks associated with it. And even my hospital, we had to heavily subsidize that. So if that hospital's not there, who's going to provide that OB care then?
Well, if it's not profitable, then other businesses are not going to come in.
Exactly. That's the point I'm trying to make. is
So I'm not sure
small
why you
rural
need
hospitals. Their
a
purpose is there
monopoly
to serve
enforced by the
their
state.
communities. And if certificate of need is not there to protect those revenue streams that make them at least marginally profitable, they will not survive. In Kentucky presently, of our small rural hospitals, over a third of them are on the verge of financial failure. Then what happens?
It's a bleak situation, certainly, but certificate
Then
of
why
need
don't we
isn't the
address
solution.
that issue rather than this particular one? You know, access to care can be defined in a lot of different ways.
Certainly.
One of them is provide health care coverage. Well, certainly. But that doesn't mean you're going to have access to care. Because if you don't have the provider that can provide that service, you're not going to have access to care. And that's the point I'm trying to make. Certificate is not going to make access to care any more available. It's not going to make it affordable. It can't.
Cost of care is lower in states that do not have certificate of need.
And that's not true.
It is.
That's not true. And I'll be
happy to
I'll
provide
be
the
glad to
reports
provide
and
that
literature on
information
that.
to show you that that is not an accurate statement. Ms. Chair, that's all I have.
Thank you, Senator Meredith. We're going to move on to Representative Proctor.
Thank you, Mr. Chair. Thank you for your presentation today. I have a question for you. One of the things I hear frequently is cherry picking. Are you able to speak to, is cherry picking a real issue in states that do not have certificate of need or from states that have recently repealed certificate of need?
That's a great question. Thank you, Representative. So we have seen several states repeal or meaningfully, significantly reform their certificate of need laws in recent years. And we haven't seen the types of cherry picking that kind of get called out as, oh, there's going to be boutique hospitals opening up. They're only going to take private payers. They're only going to take self-pay. And that's going to drain patients from hospitals. We just really haven't seen those types of impacts in the states that have recently repealed. And we've seen a good mix of rural and urban areas in those states, from Florida to Tennessee, most recently South Carolina. And really what we've seen is an increase in specialization. We've seen an increase in those surgical centers. A lot of times surgical centers that are built by the hospitals themselves that no longer have to go through the compliance costs of getting a certificate of need. So it's more specialized facilities. It's providing more options for care for folks, but we're not seeing that sort of substitution effect that has been the subject of a lot of worry and fear.
And I kind of want to follow up with Senator Meredith. So is the only way that the hospitals can make up for the cost of treating Medicare, Medicaid, or underinsured is to cost shift? Is that the only avenue for them to be successful?
Oh, absolutely not. The Hospital Association, obviously successfully in Kentucky, argued for Medicaid expansion to try and close the coverage gap. As the senator did point out, Medicaid reimbursement rates in this state currently aren't at such a level that it really covers the cost of care for a lot of individuals coming in and seeking care, often at the most expensive point of entry into the healthcare system, which is the emergency department. But the federal government and states are in recognition of the fact that these critical access hospitals are important, and they need additional funds to help cover the cost of care for people who are not able to pay or not able to pay full costs. So for critical access hospitals, there's a program called DSH payments at the federal level, disproportionate share hospitals. Those payments were supposed to go away after the advent of Obamacare and some of the additional payment mechanisms that were created as part of that. But those payments actually still exist, and state healthcare agencies negotiate on a regular basis to receive additional funds, and the hospitals themselves are able to apply for additional funds to help cover those costs when they do provide a lot of charity care to patients who are unable to pay.
Thank you. Thank you, Mr. Chair.
Thank you very much. Just as a, excuse me, I'm fighting a sinus infection. As a point of clarification, I would like to say we always talk about having a lack of hospital beds. And I think most of us in the healthcare space would say it's not a lack of beds, it's an inability to have adequate staffing for those beds. And that has to do with the workforce issue, which the General Assembly is working very, very hard to correct after previous administrations. So with that being said, we'll move on. Representative Burke?
Thank you,
Not
Mr.
Burke,
Chair.
Burke.
Thank you, Mr. Chair. I have one clarifying question and one substantive question. May I proceed?
Yes, ma'am.
Thank you. Your reference to the lit review, is that Conover and Bailey that you're referring to, their literature review?
The literature review I'm referring to was conducted by the Institute for Justice and a paper created specifically for Kentucky Certificate of Need.
Okay. Well, I appreciate that clarification because the Conover and Bailey lit review, which has also reviewed all of the research, found that the central estimates that Certificate of Need had no effect on expenditures, but they did improve health outcomes. So when it comes to Kentucky, what I'm personally concerned with is our health. And if Certificate of Need is the one lever we have left to pull to ensure that Kentuckians have better health outcomes, then for me, that's a yes. Then I'd like to ask you, the General Assembly and several committees I'm involved in, I'm on the Health Committee, we're talking about getting people off of Medicaid. We want to reduce the Medicaid rolls. We want to spend less on health. So if the state is going to take some of our most vulnerable patients off of health care and make them uninsured, because they're certainly not going to be able to afford anything in the marketplace, then what will be the result of eliminating Certificate of Need while making more people uninsured?
A quick question on that. When you talk about taking people off Medicaid, are you referring to redetermination, that process that's going on currently?
Yes, that process that's
Okay.
going on. And also we have an expressed intent in the General Assembly to reduce the amount we're spending as a state on Medicaid.
Sure. Yeah, so when it comes to redetermination, folks who would be taken off of Medicaid as a result of redetermination is because they're not eligible for Medicaid, which is actually good news from the standpoint of folks that are below a certain level of income, but above the threshold for Medicaid, are able to access fully subsidized plans on the healthcare exchange that are actually private payers. So we should actually see an influx in increasing reimbursements for care from folks that are moving from Medicaid to one of those subsidized plans. It requires a level of education for those folks when they're getting known that redetermination has found them ineligible. But those, especially after COVID and some of the bills that the federal government has passed that have increased subsidies on the healthcare exchanges, more and more people are eligible for those private healthcare plans fully paid for via those subsidies, and providers are going to see a higher reimbursement from those plans than from Medicaid itself.
Thank you.
Thank you. Again, I'm pretty straightforward in how I run my committee meetings. And one of the corrections I want to make is that the General Assembly is really not interested in taking people off of Medicaid. What we are interested in, however, is allowing people to re-enter the workforce and allow them to have more options in terms of their health care. It's a fallacy that your legislators don't want people on Medicaid, and I will not let that stand in my committee meetings. What we are for is supporting our people here in the Commonwealth and providing opportunities for them to re-enter the workforce and be able to seek gainful employment so that they have other options in their healthcare space. Thank you. We have a couple more people who have questions. I know they'll be a little short. Senator Berg, again.
Thank you very much. Just want to correct something, or I want to make sure that I understand what you said. You said that outcomes are better in outpatient surgery centers than in inpatient hospital surgery facilities?
Yes, that can be the case.
Can you document that for me, please?
Certainly, I can get you some studies on lower incidence of infection rates in standalone ambulatory surgical centers.
Okay,
absolutely.
comparing, please, apples to apples.
Certainly.
Because the type of surgeries are very, very different. So if you're going to make a statement like that, you just need to support it in this state.
I'll get you some apples to apples studies.
Thank
Absolutely.
you.
Happy to do that.
Thank you very much, Senator. And then the final question comes from Senator Meredith.
Thank you, Mr. Chair. It's not a question, I just want some clarification on this discussion about cherry picking. It's kind of a broad term, but I can show you, being a hospital CEO for 30 years, it does happen. Maybe it's not as direct as people would recognize it, but let me give you one example. My hospital had a CT scanner. Again, I've been retired for over a decade, so I think maybe the charge for a basic CT scan was $2,000. But Acme Freestanding Imaging Center says they can do it for $500 because they don't have to support an emergency room. They don't have to support OB and a myriad of other services that don't carry themselves. So insurance companies will direct patients to those freestanding imaging centers to take advantage of that cost differential, and there's really nothing that the hospital can do in retaliation to that. So it's kind of a forced cherry picking in some instances, and there just needs some recognition of that it's two different worlds we're talking about. And a lot of discussion about trying to apply free market enterprise principles to healthcare. We haven't had free market in healthcare since July 31st, 1965, when Medicare and Medicaid started. So we need to kind of set this one aside. But I just want people to understand that there are some significant challenges, unique challenges to rural healthcare that need to be identified and need to be addressed. And I would hope maybe as we continue with this task force, we can grapple with what are we trying to accomplish? Is it access to care? Is it reducing the cost of care? Is it reducing bureaucracy? I would hope we get some clarification on that in the future. But from what I've heard so far, that repealing certificate need doesn't really impact any of those. So thank you, Mr. Chair.
Thank you, Senator Meredith. Ms. Fouts, thank you so very much for your presentation. One of the things I would ask, however, is that we do not have a written copy of your presentation. Is it possible that you could provide a copy of that to the task force so we could disseminate it?
Yes, I was just talking to my state director a few minutes ago about that. We want to provide a literature packet to all of you guys with my testimony as well as the reports that I've referenced.
And as soon as you could get it to us, the sooner you could get it to us, the much better it'll be. But
my
thank you so
pleasure.
very much for the
Thank
time
you.
that you've spent this morning. We have a second set of presenters. If they would just simply come up and take their seats. We will be gentle. Yeah, Dr. Garrett. State your name, please.
My name is John Guerin, and I'm bringing up my PowerPoint here. I am testifying here as a private individual, and let me get this PowerPoint up and going here.
Before we get started, would you raise your right hand?
Yes.
Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
Okay.
And again, just to remind you, my rule on abbreviations.
Right.
Thank you.
I apologize. There are some abbreviations in this, but in speaking, I will avoid them. So I am here as a private citizen, and I list a couple of things here to give you some information about my background. I'm the BB&T Professor Emeritus of Economics at the University of Kentucky. I was there for 36 years teaching economics and being at various administrative duties, and I'm also affiliated with the Bluegrass Institute. But I issue this disclaimer that the assessments and views that I express here and in the companion report that's on the website are my own and should not be perceived as representing those of my former employer, the University of Kentucky. So I'm going to start out with just talking about some economics, as perhaps some on the committee don't want to talk about, at least market competition economics, but then also talking about the economics literature, as well as other healthcare research literature on certificate of need. So economic analysis competition is an important force in economic analysis. that generates lower prices, better quality, and more efficiency. And competition perhaps may seem as a bit of a harsh word, but really it amounts to, it's one side of the coin to consumer choice. So if you have competition, that means consumers have choices, and that's an important factor in how well businesses do. If they don't satisfy their consumers, consumers can then have alternatives. So that's important from the consumer's perspective. So any interference with the competitive process, a lot of economists think, is presumptively harmful. And certificate of need laws fit this as presumptively dubious because it impedes with the entry of competitors into the marketplace and obviously the provision of more services to consumers and blocks potential entrepreneurs from coming into the marketplace. However, this presumption can be rebutted in particular cases with sufficient evidence and reasoning to overcome that presumption. Now, to preview what I'm about to say here, my assessment is, after reviewing the evidence, that the arguments in favor of certificate of need do not rebut its anti-competitive harmfulness. So let me note here, though, that there are an assorted legal, governmental, and private institutions that support market competition in healthcare as well as other markets, and that's, of course, the desire of individual providers to not only compete right now, but to have consumers in the future, to build a good reputation for having high quality provision. But there's also legal liability for negligent treatment of patients and negligent selection and supervision of employees. There's also, and so it's important to have a well-functioning legal system that effectively sorts out legitimate malpractice claims from the false ones, so that consumers are better served, as well as the honest providers want to retain their reputation, obviously, and ferret out the dishonest ones. Malpractice insurance, even though it has its flaws, it provides incentives for insurers as well as the insured to promote quality care. And there's lots of certifications of healthcare professionals that assist providers in vetting their employees. So again, to review a little bit, my reading of the evidence implies that certificate of need laws do not generally augment or support these practices or institutions. So really add nothing to this legal, governmental, and private set of institutions that promote competition and service to consumers. So I'm going to talk about the evidence regarding the effects of certificate of need, and I'm going to take a minute here to talk about the methodologies that are used and the appropriate methodologies so that we aren't comparing apples to oranges. We want to make apples to apples, or analysts want to make apples to apples comparisons as close as possible. So ultimately this involves comparing states and outcomes in states and hospitals and providers that do have certificate of need to those without, and by various means such as costs, provision of care, quality of outcomes, and so on. Now, it's important, obviously, to adjust for relevant differences across states or across healthcare markets, such as income, poverty rates, cost of living, and so on, underlying morbidity, and other demographics. So more data on those things, the better the study is. Also, many studies allow each state its own baseline and examine changes after certificate of need is, or some parts of certificate of need is removed. So rather than trying to ferret out why Kentucky might be less healthy than, let's say, Indiana, we give Kentucky a baseline and Indiana a baseline, and when Indiana repeals certificate of need, let's look at the change in these outcome variables in Indiana and compare that to the change in Kentucky, say. So this is sort of like kind of a, not exact, but sort of like a treatment control groups. The treatment group would be the states that change their CON laws, and the control group would be those that do not. And we see what happens to each of the, quote, patients, end quote. And Kentucky is in these studies. They're typically, obviously, it would be in the so-called, what I'm calling the control group that hasn't changed its CO and laws. So there are two, there's more than two reviews, but two reviews I'm going to point to of this. One of the studies is one summarized in a Federal Trade Commission and Department of Justice document of 2016 that I referred you to here, as well as the Institute for Justice review and survey that was referred to earlier that I think probably has been sent to you, I believe. You probably all have. So I want to talk about specific findings and what the arguments have often been in favor of CON as being, certificate of need, as being an exception to the rule of the need for competition. First of all, sometimes there's a claim that certificate of need reduces healthcare costs, but the studies are suggest that this, in fact, pretty strongly suggest that this, in fact, is not the case. Most studies find that certificate of need does not restrain items such as per diem per case or per capita hospital costs, and often are associated with increased costs. Second question is about certificate of need and the quantity or the amount of health care provided. Studies imply that certificate of need does not promote more health care provision and generally less. So I cite as an example here the Institute for Justice study review of 80 studies. 63 indicate a reduction in supply of healthcare services and 11 show no change. And this again applies to such things as on per capita basis, fewer hospital beds, fewer admissions, fewer physicians, and fewer imaging services. Now, what I think this indicates is that, of course, just the outcomes here of this healthcare or social science outcome is not majority rule, right? There's some outcomes that in fact do and have occurred, and so this requires more than one study, and but the preponderance of these studies shows, in fact, the quantity of health care provision is lower with certificate of need. Now, perhaps the two questions, or actually I got two on this page, one on the next, that are most contentious, are most serious perhaps, is the question of whether or not certificate of need laws improve health care availability to the underserved. Many have contended that, and that is in contention here by some on this committee, it seems. So the studies that are out there show no clear pattern of more access to the underserved in certificate of need states. In fact, I quote here from the Federal Trade Commission Department of Justice study, quote, "Although advocates of certificate of need laws might seek to promote indigent care, the evidence does not show that certificate of need laws advance that goal." Again, this is the evidence regarding states that have less or have reduced their certificate of need restrictions. The other comment I have on this slide. Does certificate of need improve the quality of healthcare provision? Most studies show that diminished or unchanged quality of care in certificate of need states as measured as such things as rehospitalization rates and mortality rates. Again, to quote the Federal Trade Commission Department of Justice study, they conclude, quote, "The weight of this research has found that repealing or narrowing certificate of need laws is generally unlikely to lower quality, and it may, in fact, improve the quality of certain types of care." And then somehow does certificate of need help address market imperfections? There are many interferences in the marketplace in healthcare. There's no doubt about that. And there are some issues here that apply not only to healthcare, but other markets as well, such that consumers are oftentimes not very well informed. There's government or third-party insurance that are in the middle of this, and there's a host of other federal and state regulations as well as constraints by insurance. So does the entry-limiting activity of certificate of need, that is prevention of new providers in many cases, does this help address these issues? And I don't see any clear reason how this helps consumers with their decision-making or eases the handling of other regulations. And the evidence suggests that it does not improve the quality of healthcare provision. So this is my concluding slide. I conclude that the arguments made to justify certificate of need, do not stand up to careful examination. That is the entirety of the evidence. That we're trying not to cherry pick the evidence, but look at its entirety. And again, my conclusion here is that the benefits of competition into healthcare markets and entry into healthcare markets is not rebutted. Of course, every state situation is unique, including Kentucky's situation, but I think the weight of the evidence suggests pretty strongly that Kentucky would be well served by the improved access to healthcare that is stimulated by the removal of certificate of need. That's all I have. Thank you.
Thank you very much, Dr. Guerin. Senator Berg.
Thank you, sir. I'm sorry to talk so much. I have a question, though. When you talk about utilization, quantity being
Correct.
lower, and I'm assuming you're talking about availability of imaging slots, availability of OR. When you say that the quantity is lower, are utilization rates higher? Because utilization
question.
goes to the cost of delivering the service. If you have the same providers, doing a service 60% of the time versus 90% of the time, you're actually spending less money when your utilization rates are higher.
Sure.
So can you balance that for me?
I don't have that off the top of my head. I do, but there is the evidence on costs, though. Costs are higher, and the evidence suggests pretty strongly the costs are higher in certificate of need states.
Charges or payments?
Total costs, which either come out as, it's the cost that the hospital incurs.
How does CON affect the cost that the hospital incurs?
Well, I guess ultimately, that's a good question, but that's what the evidence suggests.
Is it related?
Well, cost per unit, that has to be paid by somebody, right?
Yeah.
Yeah.
But it doesn't make, I don't see how one would affect the other. It could be true and not related.
Well,
That's what
okay, I'm
wondering.
relating the evidence to you on this.
Yeah. Thank you. One other point,
Proceed.
and this is just a caution to everybody. Because somebody is trying to sell you a service does not mean, one, it's a service you need, or two, that it's a better service. And I want to warn consumers in the healthcare market, because most of us as consumers are uneducated consumers. We don't even get the option to know enough that we need to know to be able to make educated, because of the way the system is rigged at this point. You can't even tell what you're paying. You can tell what you're going to get billed. You have no idea what you're going to pay. I just want to warn people, when you've got people out there advertising to you in a healthcare market, my advice is be aware and be warned. Because we're here to take care of people in need. We are not supposed to be here trying to get patients with money to come to our facilities for stuff that we know we're going to make a profit on. And that therein, sir, is my concern. Thank you.
Thank you, Senator Berg. Next, Senator Meredith.
Thank you, Mr. Chair. And you made the statement that, or the question was posed, does CON, certificate of need, improve health care availability to the underserved? And you say no. But can you answer unequivocally that CON doesn't impact this at all?
I'm not saying anything of the sort. In fact, these studies suggest that there are impacts.
Let me share a question, a situation with you, followed by a question, if I could, Mr. Chair. You've said, in essence, that you don't see that certificate of need has any relative value to the healthcare delivery system. I mentioned, I'm sure you heard earlier, that my small hospital is one of the last to offer obstetrical services in the state of Kentucky. And I had a nursing assistant come to me one day, and many of my colleagues have heard this story, and I'm sorry I'm repeating it, but it just kind of frames the issue. Nursing assistant walked in on a patient, 18-year-old, who had delivered a premature baby. Baby was sent to a hospital in Louisville, 70 miles from Litchfield. And the nursing assistant found the mother crying, so she's trying to console her and tell her everything's going to be fine. Baby's at a great hospital. We'll see the best of care, and everything will be okay. And the mother replied, that's not why I'm crying. Well, what's your problem? I don't have the gasoline money to drive to Louisville to see my critically ill baby. So it goes back to the issue of choice. The next nearest hospital to mine is 30 miles away. And say, well, that's an easy trip, unless you're truly economically disadvantaged. And then it is a tremendous burden, financial burden to many of our citizens. So are you saying that there is no value in the certificate of need in securing the healthcare safety net for rural Kentucky?
Well, I think it's important to help secure the healthcare needs of folks in rural Kentucky as well as the entire Commonwealth. The question is, what I'm addressing is there evidence out there that we can get our hands on and point to and replicate where states who have repealed or scaled back their certificate of need laws are having these big problems with increased or a lack of access to by rural folks or the indigent folks.
Well,
And what I'm seeing in the evidence, the studies I've reviewed and the surveys I've looked at, is there is no systematic reduction in that regard.
but maybe you're looking at the wrong variables, particularly for rural Kentucky.
Well,
the
that would be-
payment methodology for providers is truly discriminatory. It's significantly less than our urban counterparts. And I've asked the question repeatedly of our managed care organizations and Secretary Freelander, why would anyone choose to practice in rural community knowing you're going to make 25 to 30% less than your urban counterparts? And nobody has an answer to that question other than unless you've got a passion for it. Many people do, but that's not fair to penalize those folks. But I say that has more to impact the availability of care in Kentucky than certificate of need does. And maybe that's where we need to be focused on our efforts, and maybe that's what we need to be examining rather than whether CON actually impacts the amount of care that's available in Kentucky. Because again, I think one of the limiting factors is we don't have enough personnel to provide the care to begin with. So I think it's kind of a red herring to suggest that CON is the problem with access to care in Kentucky. Thank you, Mr. Chair.
I would not deny that there are other factors. I think that's very important to consider other factors here. But my commentary has to do with the evidence out there of what has happened in other states regarding their rural care and care to the underserved, and not that certificate of need is the sole factor that determines the quality of health care.
Mr. Chair, if I could, I think the problem that we're dealing with is kind of like we're saying on the average. And, if we rely on average, no one would ever drown in the Rio Grande River because in the summertime, the average depth is 3 foot. So what I'm saying is Kentucky is not average. We got a lot of outlying situations, particularly for the poverty that we have in rural Kentucky, and even some of our urban areas are suffering the same problems. And that's the common denominator is the poverty, and that's what we need to address, not this regulatory burden that suggests that it's costing more to provide health care. I don't think it impacts it. So thank you, Mr. Chair.
Thank you very much. We're going to move on. Representative Whitten.
Thank you, Mr. Chair. Thank you, Dr. Guerin, for your testimony. I just had a clarifying question. We talked a lot about hospitals, and I would just wanted to ask you if your opinion of the removal of certificate of need includes all categories, including ambulances and other nursing facilities. If your opinion that it should go across all categories,
Well, I
or
think-
if that needs to, or if we need to look at it differently.
I think the studies have looked at a lot of different aspects of healthcare provision, and they usually come with the same answer, that it doesn't deliver what is claimed. And so my first reaction would be that no, we should not have certificate of need on healthcare services in general. Now, you might be able to make an argument. Again, that's my presumption. If you can come up with a specific case and specific exception to that, that presumption is rebuttable. But my initial reaction, again, is that no, we shouldn't try to limit providers into different markets.
Moving on, Senator Gibbons has a few questions.
Mr. Chairman, thank you. And Dr. Guerin, right?
That's correct.
Certainly have enjoyed the conversation and had the chance to look at your CV, and you're well published in a number of different areas. If I had a third or fourth life to live, I'd love to do a little bit of what you do because it looks quite interesting.
Thank you.
Share with me the original. I've noted on the front. This is a revised August 2023. What was the original publication date of the paper? Do you recall by chance or range?
It was one version in late 2018, another in mid 2019, and I've subsequently updated some of the material in there.
So your CV indicates a broad range, as I mentioned, of different topics. What drew you to this one? What prompted you to say, I'm intrigued by this? Was there someone that came to you and asked you to do it?
I was asked to do this, yes, but it's a general interest of mine is the role of government in an economy, and this is an aspect of that.
Very good. The role of government in an economy, and I saw that reflected in a number of your different publications. And Mr. Chairman, if I could have some latitude, because I'm fascinated by the presenter.
Proceed.
Speak broadly to your view of the role of government in economies, and what is the role of government typically positive, negative? How does government influence economies?
Right. Well, it can be positive. In fact, on one of my slides here, I talked about how there's a set of legal and governmental and private institutions that work together to support a marketplace, and these are like good liability law, good tort, property, and contract law, a good constitutional law, criminal law, and those kinds of things are typically the functions of government. And having those kinds of things are critical to a modern economy and allowing people a freedom. But of course, we don't have a freedom to cheat or harm other people. And so that's a real fundamental aspect of government that I think should be promoted. And it does assist people of not. It doesn't determine what people do, what occupation I go into, or what a business I open, or what job I take. But it does determine things like, here's the rules, and if you go beyond this line, you're cheating someone, it's fraud or malpractice or something. If you go beyond this line, you are interfering with someone else's person or property. And so it doesn't dictate what people do, but it does set on clearly the bounds of what we can do. And I think having government do that is a real essential function.
I think very well said, and I sense that you and I share a lot of the same thoughts with regard to government providing stability, security, those fundamental keys for economies and systems and communities to operate, and I concur with you on that. It was interesting as I was reading through your work product that was included in our packet of information, and then seeing your slides. I particularly appreciate the fact that your third bullet there on the conclusion slide makes it clear that every state situation is unique, And so as we evaluate this issue of certificate of need, it is important that we try to do that in and through the lens of Kentucky. Your slide that you had a few back, if you could back up, there was another slide that I found interesting, and it was titled, "Does CON help address market imperfection?"
Right here.
Great. And again, I'm gonna briefly take some latitude, if the chair will permit it, to move off of the CON conversation briefly to move to the complexities. We've had this conversation about the foundational role of government in economies. Somewhere along the way, and this comes from a conversation that I had years ago, having served on health and welfare for a number of years and worked in the budget process and watched the influences of some of these bullets, particularly that you've got on this slide. Someone much wiser than I said, David, meaning me, if we had the chance to rebuild from scratch the delivery of health care in the United States, we could do it so much better than we do today. We've arrived at this place with all of these influencers. I think my colleague Senator Berg spoke to the underinformed consumer. Wouldn't it be ideal, I would think, in an economic environment if we had consumers that were much better educated? You agree?
Sure.
And I think it'd be so much nicer, this third-party payer sort of model and the government involvement in that payment process. Boy, if we could restart the delivery of health care, we would do that differently, I think, as well, because it seems to have an outlying influence on the way consumers operate. If I'm not paying for it, I'm going to operate differently. So I really appreciate this slide about all of those different influencers. The one I'll encourage you, and I don't know how to put this in an academic term, but I think this plays a role, and I find myself guilty of it as well. And so I'll conclude with this statement and would love for you to respond to it. Of all the things that we shop for as consumers, healthcare we do so differently than anything else because we're so driven by emotion. We're so often in my mind, logic is cast aside, and emotion drives a lot of the decision making that is made in the healthcare space. Agree, disagree, speak to that thought. That's all I've got.
Well, I don't have a study that I can point to in that regard, but it's probably true. And it is, some of the healthcare decisions can be gut-wrenching, but a lot aren't. A lot are kind of everyday. Should I go to the doctor because I'm not feeling, I've got a stuffy nose and whatnot. But yeah, some clearly are kind of gut-wrenching decisions. And I don't think there's any magic wand we can wave or a government bureau that we can create to help that. Those are things that, in my view, again, I'm getting outside my economics here, but in my view, that you really need family and good friends and good, honest providers you can talk to and through things like that.
Good. Thank you for the latitude, Mr. Chairman.
You're very welcome, Senator. Thank you so very much, Dr. Guerin.
You're welcome. Thank you.
We really enjoyed your patience and your presentation. Thank you. Now, with that being said, we have some personnel from St. Elizabeth Healthcare who will be approaching the table. I want to thank you all ahead of time for your patience and also for the information that you're going to provide to the task force. Again, I will ask the same of you as I have of everyone. We want to make sure that, first of all, that our public is able to understand what it is that we're talking about and the issues that we are concentrating on. So no abbreviations, please. First of all, I'll have you introduce yourselves for the benefit of the committee and those watching.
Thank you, Chairman. I am Sarah Giolando. I'm the Chief Strategy Officer of St. Elizabeth Healthcare.
Thank you.
Mr. Chairman, I'm Mark Guilfoyle. I'm a lawyer with DBL Law in Northern Kentucky.
Thank you. Now, will you please raise your right hand? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you so very much. Proceed.
Thank you, Chairman Douglas and Chairman Weber, for including St. Elizabeth in this important endeavor to educate this legislative body on the complexities of the Certificate of Need process. I would like to share a little bit about St. Elizabeth Healthcare today and why we are passionate about protecting safety net hospitals through reasonable modernization efforts of the Certificate of Need program in Kentucky. St. Elizabeth was founded before the Civil War with a mission to serve those less fortunate in northern Kentucky with Covington's First Hospital. While our mission has remained the same for more than 160 years, we set forth with an ambitious vision in 2016 to lead the region to becoming one of the healthiest in the United States. Today, we invest more than $100 million each and every year on initiatives that improve the health of the people that we serve. From its humble beginnings, St. Elizabeth has grown into a comprehensive health system with 5 hospitals and an integrated medical group of both primary care and specialty providers. Both our physician group and hospitals have received dozens of national awards for delivering the highest quality and patient experience. St. Elizabeth has been ranked number 1 or number 2 in Kentucky by U.S. News and World Report for consecutive years. And St. Elizabeth Edgewood just recently received a 5-star designation, the highest available, from the Centers for Medicare and Medicaid Services. The American Medical Group Association has awarded St. Elizabeth Physicians, our employed medical group, the exclusive Acclaim Award as the best integrated physician group in the entire nation. But it wasn't that long ago that there were 2 hospital systems in northern Kentucky, one of which was managed by the Cincinnati-based Health Alliance. The Cincinnati health systems were focused on expanding to the lucrative northern Cincinnati suburbs, and they starved the northern Kentucky-based St. Luke hospitals of needed capital and other resources. Northern Kentucky patients were routinely referred to hospitals across the river in Ohio for any kind of complex care. Without the needed investment from the Health Alliance, unfortunately, the quality of the St. Luke hospital suffered. Their frustration led St. Luke to seek to exit the Health Alliance, and they eventually merged with St. Elizabeth Healthcare in 2008. Since then, St. Elizabeth has invested more than $400 million in technology and capital improvements in the 2 former St. Luke hospitals, now called St. Elizabeth Florence and St. Elizabeth Fort Thomas. We have 1 integrated medical staff. It's comprised 55% of independent providers from the community and 45% members of our integrated or aligned and employed medical staff. Providers from any healthcare system or practice are welcome to apply to St. Elizabeth's medical staff. It's what's called an open medical staff. This medical staff shares 1 medical record system, which enables us to deliver integrated and coordinated care to our patients. The merger was thoroughly vetted by the Federal Trade Commission, which concluded that the combination of the 2 hospital systems did not create a monopoly because northern Kentucky is part of the larger greater Cincinnati market. In fact, northern Kentucky has been considered part of the Cincinnati metropolitan statistical area since 1950, as the proximity between the 2 simply is the span of a bridge. Greater Cincinnati is a tri-state region encircled by a large interstate ring road called I-275. The Cincinnati Airport is even located in northern Kentucky. So when the Federal Trade Commission examined the impact of the merger of St. Elizabeth and St. Luke, they recognized what we see today. Most northern Kentuckians are only a few miles away from several other health systems. Today, Greater Cincinnati features 18 different acute care hospitals from 6 different healthcare systems, a fact that makes the region among one of the most competitive markets in the United States. On the graph here, this is a showing of market concentration, which is the standard way to measure the competitive nature of a healthcare market. And you can see that Cincinnati is towards the left, towards the side of perfect competition. For comparison purposes, Louisville features 8 acute care hospitals, and Lexington has just 5. More than 60,000 Northern Kentuckians cross the bridge each day to go to work in Ohio, and about the same number of Ohioans cross the bridge south to work in Kentucky. It's considered one big market. Beyond hospital facilities, it's very important to look at access to physician offices and to outpatient clinics, as that's where people receive most of their care, and that is where the biggest growth in our industry is occurring. There is no barrier to establishing physician offices or outpatient clinics in Kentucky. Those are fully exempted from the Certificate of Need process. That's why Northern Kentucky is home to more than 100 independent physician offices, clinics, and urgent care centers, many of which are affiliated with other healthcare systems, including the Christ Hospital, UC Health, and Cincinnati Children's Hospital. There are also 109 Certificate of Need approved services in Northern Kentucky, and only 19 of these are St. Elizabeth facilities. Well, I don't know why I'm having does not want to go down. Oh, there we go. Let me go back one. Sorry about that. The idea that Certificate of Need has somehow limited the choice of healthcare services in Northern Kentucky is simply not true. Even in our competitors' advertisement, they notice that they have choices. Northern Kentuckians have choices for care. With so many competitors already in the market, you might wonder why St. Elizabeth cares so much about maintaining Certificate of Need. Certificate of Need protects the vital services of safety net hospitals by limiting unfair competition. It's important to understand that healthcare does not operate in a free market. Nonprofit hospitals are required to see and treat anyone who shows up on their door for emergency care, regardless of their ability to pay for those services. No other type of provider is required to follow this law, called the Emergency Medical Treatment and Labor Act, also known as EMTALA. The government is the largest payer for healthcare services. Approximately 75% of most nonprofit healthcare systems patients are insured by either Medicare or Medicaid, and those prices are fixed. Unlike a free market business like your local grocery store, healthcare systems are told what Medicare and Medicaid will pay for a service. There is no ability to raise prices when costs increase. So while the cost of your grocery bill has gone way up because of recent inflation, Medicare is still paying healthcare systems the same price. Even when healthcare systems are having to pay 3 to 5 times more for contract labor in today's tough market, those additional costs do not get passed on to our patients. Other states have repealed Certificate of Need, and there have been unintended consequences experienced. Since Florida repealed its Certificate of Need laws in 2019, companies announced plans to build at least 65 new facilities in Florida, but these were really concentrated in the urban areas, which are now suffering from excess capacity and increased costs. Meanwhile, there are no hospitals being built between Jacksonville and Pensacola, a more than 300-mile stretch of rural counties. Hospitals are not being built in areas that need it the most, and instead, they're growing in markets that yield the highest profits and are already very well served. Another example can be found in Texas, one of the first states to allow freestanding emergency departments to be licensed. The state went from a handful of freestanding emergency departments to more than 200 in just 10 years. After a flood of patient complaints about surprise bills from these unaffiliated centers that did not accept many insurance plans, the legislature had to pass new laws to try to fix the profit-seeking behaviors that ensued. Closer to home, we have seen that same trend. Many Cincinnati hospital systems built satellite hospitals in the lucrative northern suburbs, where one health system enjoys an unbelievable 75% commercially insured patient base. Health systems are not the only players keeping an eye on Certificate of Need changes. One of the biggest threats comes from the insurance giants, who have the financial resources and incentives to build surgery centers to pull out profitable business from the healthcare systems. United Healthcare owns one of the largest ambulatory surgery center businesses in the nation, operating 320 such centers, mostly concentrated in urban markets. United Healthcare is also the largest employer of physicians in the nation, employing 70,000 physicians. It's one of the largest pharmacy benefit managers, and it provides health insurance to more than 50 million Americans. They are literally building a health system without hospitals, picking off the profitable pieces of business and leaving the rest for the safety net providers. The truth is that repealing Certificate of Need will not create more access for most Kentuckians. It would simply invite outsiders into our state to cherry-pick profitable business that would harm the existing healthcare systems providing safety net hospitals or services to their communities and those operating in rural markets, which are unlikely to see any new investment from a repeal of Certificate of Need. To provide additional perspective, I would like to introduce Mark Guilfoyle, a partner at DBL Law and a Certificate of Need expert.
Thank you, Mr. Chairman. We do appreciate the opportunity to be in front of the task force here this morning. My name is Mark Guilfoyle, and as a lawyer, I've represented hospitals in CON cases in northern Kentucky, Lexington, Louisville, Paducah, Bowling Green, and Prestonsburg. I've represented hospitals that were applying for a Certificate of Need, and I've represented hospitals that were opposing a Certificate of Need application. Let me begin by stating that St. Elizabeth opposes the outright repeal of the CON law. Objective Kentucky data demonstrates that Certificate of Need provides significant benefits. And we think this slide here demonstrates why it is very dangerous and not proper to rely on out-of-state data. So what we see here is that CON ensures access to hospitals. Kentucky has more hospitals per 100,000 population than states with no Certificate of Need laws. We have 1.5 times the number of physicians per 1,000 square miles than states with no Certificate of Need laws. Certificate of Need strongly supports access in rural areas. And if you look at this blue box on the slide, you'll see that currently there are 11 rural hospitals in Kentucky that are at risk of closure if CON is repealed. That comes from the Ascendient report. And CON contains costs. Kentucky costs are significantly less than costs in non-Certificate of Need states. Senator Meredith, I'll come back to that. That was one of your questions. What we are presenting is not academic theory. So Dr. Guerin stated, Senator Gibbons, as you noted, that every state, including Kentucky, is unique. But he didn't give you one Kentucky data point. And Ms. Fowles talks about 128 pages and decades of research, but she didn't give you one Kentucky data point. These theories that have been presented before us here today do not trump the facts on the ground here in Kentucky. Now, let me tell you what we are in favor of. We support the modernization of Certificate of Need, and we have a long-standing record of doing that. We supported House Bill 444 in 2018. We supported House Bill 777 in 2022. And most importantly, over decades, we have worked with the Cabinet for Health and Family Services to update the state health plan when it's updated annually to relax Certificate of Need criteria that are contained in the state health plan. We are not opposed to modernization, and we stand ready to continue to do that. Now, let me talk about two separate federal courts that have, just in the last 2 years, have addressed our Certificate of Need law. The first case involved home health services, and Ms. Fowles talked about this. This is the Tawari case, the home health case in Louisville, where the applicant wanted to have a Certificate of Need to serve Nepali residents and Nepali patients. This was notwithstanding the fact that federal law already requires that you have translation services available, okay? So, an outside national group came into Kentucky and filed suit in federal court challenging the Certificate of Need law. And District Judge Stivers upheld the Certificate of Need program in Kentucky, finding three benefits that are very relevant to our purposes here today. He found that the CON law promotes greater cost efficiency. He found that it encourages agencies to invest in quality improvements. And he found that it helps ensure access for all patients. Significantly, for our purposes in northern Kentucky and statewide, he found that the proliferation of agencies would lead to poaching profitable patients, and it would leave low-income patients without access to care. Again, that's one definition of cherry picking, and I like it because that's what Judge Stivers found. Judge Stivers upheld our law. He found discrete benefits in our Certificate of Need law, and his decision was affirmed by the Sixth Circuit, which is one step below the U.S. Supreme Court. A second case that I want to bring your attention to involved ambulance services. It too was filed by an out-of-state special interest coming into our state trying to dictate what we're doing here in Kentucky. And District Judge Van Tatenhove upheld Kentucky's Certificate of Need law, and he too found that the CO Certificate of Need law provides benefits. It helps ensure access to ambulance services. It reduces the need for additional tax revenue for emergency medical services, and it incentivizes providers to serve underserved, disadvantaged areas. We've talked about that already here today. These are findings by a federal court. The bottom line, conservative federal judges in Kentucky in just the last 2 years have identified palpable benefits of the Kentucky's Certificate of Need law. The Certificate of Need law does not restrain trade. It does promote cost efficiency. It does promote quality of care. It does ensure access to health facilities and services. Again, these are data-driven facts here in Kentucky. Now, let me debunk a fundamental myth about CON being a problem in northern Kentucky. The simple fact of the matter is that Certificate of Need is not a barrier when it comes to the deployment of health services in northern Kentucky. Since 2015, of the 61 Certificate of Need applications that were filed in northern Kentucky, only 3 were denied. And that is on par with the state average. 94% of Certificate of Need applications in Kentucky are approved. And since 2015, St. Elizabeth has only opposed 1 Certificate of Need application. And we did so to prevent cherry picking by a Cincinnati competitor, and we prevailed in the Kentucky Court of Appeals. Now, Senator Gibbons, you noted the cover of Dr. Guerin's paper where he noted that his paper was submitted to the Kentucky Court of Appeals in this very case, and the Kentucky Court of Appeals rejected each and every one of Dr. Guerin's theories in that case. Certificate of Need applications are routinely approved in northern Kentucky and indeed throughout Kentucky, and St. Elizabeth is undeniably hands-off when it comes to opposing Certificate of Need applications. Now, if we go back 18 years, St. Elizabeth has only opposed 1 other Certificate of Need application. That was back in 2005. In that case, St. Luke Hospitals applied for a Certificate of Need to establish an open heart surgery program. And at the time, St. Elizabeth already had a high-quality interventional cardiology program. We were able to prove a basic tenet of specialized care, namely, the higher the volume of specialized procedures, the more proficient the surgeons and their teams become at those procedures, and hence the higher quality of care. So if you're going to have open heart surgery, you want to go to a surgeon who's very experienced at it. You don't want to go to a rookie if you have a choice. By the way, Dr. Guerin agrees with that basic principle. The introduction of a second open heart program in our community would have depleted the volume at St. Elizabeth, and our community would have been left with potentially 2 mediocre programs because the volume did not exist to support 2 high-quality programs. This is a clear case right here in Kentucky where competition for competition's sake is simply not good for the community. And since St. Elizabeth successfully opposed St. Luke's open heart application, St. Elizabeth's interventional cardiology program has become a national leader. Healthgrades just recognized St. Elizabeth as one of only 81 hospitals in the nation, and the only one in Kentucky, to achieve excellent critical outcomes for heart bypass surgery and heart valve surgery. St. Elizabeth was right to avail itself of the ability to oppose the certificate of need application in 2005. We were right to oppose it, and our patients have obviously benefited from that. Now, I think everyone understands, and we've talked about it, that St. Elizabeth is the safety net hospital in northern Kentucky. We are the institution in northern Kentucky that cares for the Medicaid, Medicare, and self-pay populations. When a competitor hospital cherry picks commercially insured patients from a safety net hospital, that greatly increases the burden on the safety net hospital and compromises its ability to reinvest excess revenue back into the community. Senator Meredith was spot on here. Now, what this slide shows, in the chart that you can see there, it shows how the 4 Cincinnati hospital systems that are listed below St. Elizabeth Healthcare, they're capturing significantly more commercially insured patients from northern Kentucky. These are northern Kentucky patients, Boone, Kenton, Campbell, and Grant counties, than is St. Elizabeth. That's where the money is. These Cincinnati systems are trying to suck the commercial payers over across the river. That's what we call cherry picking. And members of the task force, cherry picking is already underway in greater Cincinnati. And this hurts the safety net hospital. Over in Cincinnati, the University of Cincinnati Hospital is the safety net provider, but they get a $41 million a year tax subsidy to help them. We don't have that at St. Elizabeth. Now, let's talk about, Ms. Faust stated that the sky hasn't fallen in states that have repealed CON. That's not true in Ohio, right across our river. The experience in Ohio shows how hospitals, once free from CON, will only deploy profitable services, which in turn only increases cherry picking. When Ohio removed CON, ambulatory surgery centers, which are proven moneymakers, exploded from 27 to 179 in just 3 years. Senator Meredith, I think if we looked at a map, we'd probably see that a lot of those were put, in the rural areas or just next to the rural areas to further deplete what rural hospitals have to contend with. This is a key point. Ambulatory surgery centers do not have to accept Medicaid or Medicare. They do not. That federal law that Sarah talked about only applies to hospitals. And Ohio's healthcare costs are significantly higher than Kentucky's. 14 hospitals closed in Ohio when the CON requirements were removed for hospitals. That's a fact. Now, the slide on this particular slide, Senator Meredith, to your point about how do costs compare in Kentucky versus non-certificate of need states. That first line shows you we're lower. That's significantly lower than Indiana, Ohio, Florida, and Texas. But what we wanted to do was show these other metrics below the first line to show that in Kentucky, we are caring, comparatively speaking, for a poorer, more rural, less healthy population than these other states. So we've got to be careful that we're comparing apples to apples when we look at other states. And I would say the $6,561 price per inpatient discharge, a real live metric, is particularly impressive when you consider the challenging population that Kentucky hospitals are caring for. Let me just say a couple words about the FTC report that both Ms. Fowles and certainly Dr. Guerin alluded to. Keep in mind that the FTC's mission is, quote, to enhance public understanding of the competitive process, close quote. The FTC likes competition. They're in business.
Excuse me.
Yes, sir.
We've gotten into the area of using.
Oh, I'm sorry, sir.
Okay.
I really apologize.
That's okay.
Federal Trade Commission.
We are listening.
Yes, sir. I don't doubt that for a minute, and I do apologize. Thank you, Senator Schickel, for calling me out on that. The Federal Trade Commission, and there was another, when you look at Dr. Guerin's slides, there's another one, DOJ, that's Department of Justice. It was a joint report But the Federal Trade Commission is in business to promote competition. No surprise there. It has no healthcare expertise. So we'd like to direct your attention to the comments in that report of Commissioner Brill, who said that the Federal Trade Commission does not, quote, possess sufficient relevant information to opine on non-competition related policy goals of the CON laws. She continued, competition is not a panacea for all of the problems with American healthcare. She concluded, we, the Federal Trade Commission, lack evidence of the broader impact of Certificate of Need law repeal. That's what that report says. So I would encourage us all to read it carefully. Let me conclude just by stating that when one considers the decisions by Kentucky state and federal courts, when you consider data comparing Kentucky and non-certificate of need states, and when you consider St. Elizabeth Healthcare's own real-life experience in a greater Cincinnati healthcare market, it's pretty clear that certificate of need is helping to ensure access to quality care. It is helping to protect safety net hospitals like St. Elizabeth. It is preventing out-of-state interest from cherry-picking profitable Kentucky patients, and it is succeeding in protecting rural healthcare access. Thank you, Mr. Chairman.
Thank you all for your presentation. Representative Proctor has a question.
Thank you, Chair. I've got a clarification and then a question.
Proceed.
So thank you for your presentation. I appreciate that. Mr. Gallagher, are you saying that St. Elizabeth does not get any taxpayer subsidy?
I'm not at all saying that. We do have some of that in our dish payments and the like. My point was that if there is another safety net hospital in our greater Cincinnati healthcare market, and it has a big subsidy that we don't have, and that is an annual $41 million infusion, University of Cincinnati.
Thank you. And I have a question, Chair. Has St. Elizabeth purchased and closed any hospitals in the rural areas?
Well, I can tell you that if you're speaking of Owen County.
That's one.
Thank you. Well, I'll be happy to address that. And I know there's been some talk offline, Mr. Chairman, on this, so we do appreciate the opportunity to address that question. Thank you, Representative. St. Elizabeth has provided tremendous support to Owen County over 7 years. In 2016, we purchased a hospital building that was empty. It had no patients, and it was seeking bankruptcy. We went in and bought the building, and we thought, well, this would be a great opportunity to provide emergency room services and outpatient services. We did that for 17 months, and we lost $3 million. So we looked at the data. Why isn't this working? And what we found was that many Owen Countyans were going to other hospitals. There are 4 within 36 miles for significant emergency or emergent conditions. They weren't going to our emergency department if they had something really bad. They were only coming to us for urgent care. So we went back to ground zero and we said, well, why don't we renovate a separate building in Owen County? And we spent $17 million to do that. And that was for urgent care outpatient services along with imaging and lab. That was Plan B. We partnered with HealthPoint. They lost money. They pulled out. Then came Triad. And we saw, Mr. Chairman, that there was to be some conversation from Triad here this morning. They're not here, and that's fine. That's their prerogative. We like to think it's because they're pretty happy with the partnership that we have in Owen County. But Representative Proctor, we're still losing money in Owen County, but we are committed to working with our physician partners in that county. No one is going to build a hospital in Owen County. No one. Co-Chairman Weber is in Bullitt County. There's finally going to be a hospital down there in Bullitt County that has 82,000 people. Owen County has 11,000 people. You're not going to have an acute care hospital. And in fact, There's 43 counties in Kentucky that don't have one hospital. There's only 8 that have 2 or more. So Owen County's not going to have a hospital. We didn't buy a hospital and close it. We bought an empty building, and we came up with ideas for how we could better serve the people of Owen County. So, certificate of need is just not a barrier to the deployment of health services in Owen County. And if by some chance someone wanted to come in and build an acute care hospital and file a certificate of need to get one, we would support it. St. Elizabeth would be there to support it. And I've been authorized by our CEO to tell you all that here today. So we're proud of our record in Owen County. No, we have never closed a facility in a rural area, and we don't plan to do so anytime soon. Our Grant County Hospital, that's a rural county. We're very happy with our operation there. Thank you.
Can you speak to Dearborn, Indiana, the freestanding birthing center?
I'm not sure I can. Maybe Sarah?
Yeah, no, I'd be happy to. So there is no freestanding birthing center in Dearborn County. So Dearborn County is a rural hospital that we acquired during the pandemic after they were in dire financial straits and would have to close their facility. So they came to us. We partnered with them. We already had significant physician presence in the market. And so we've been investing in the hospital. We told the community at that time, when we were speaking to their community representatives, that we plan to continue hospital operations in Dearborn County, and that's gone very, very well. The one area that we said at the time of our acquisition that we were uncertain whether it could be supported was the OB services. And the reason that is that there was less than 1 to 2 births per day were occurring in that hospital and in that facility. And there was difficulty in attracting the appropriate level of staff that could care for those patients in that area in Dearborn County. And so we made the very difficult decision after we saw an additional decrease in our birthing volumes there after we acquired the hospital. They continued to decrease, so the community was going elsewhere for care. And for their deliveries. So we made the difficult decision to cease those OB services in that facility. They are still operating today, but they will close likely by the end of the year. So we've worked with Margaret Mary Hospital, that's a nearby hospital, and also informed Mercy Hospital. Both of those are within 30 minutes, and then Edgewood are the 3 options for people. We are committed to maintaining prenatal and postnatal services, so we're doubling down on investments with additional OB-GYNs in the market so that most of the care can be received directly in the county. Does that answer your question, Representative?
It does, but it sounds like these are the very services that Certificate of Need was supposed to protect so that you wouldn't have these closures.
There is no Certificate of Need in Indiana, so that's a different regulatory environment that's happening. So I think any provider could certainly come into Dearborn County and establish a birthing center without any Certificate of Need requirement in the state of Indiana. It's a very different regulatory environment. Thank you.
Senator Schickel.
Thank you, Mr. Chairman. I have want to ask permission to make one comment, and then I have a question also. Thank you, Mr. Chairman. I represent where St. Elizabeth is. Up until several years ago, I represented where both of St. Elizabeth's major hospitals were there. I love St. Elizabeth Hospital. Every time I've had a surgery, it's been at St. Elizabeth Hospital. Every time at 2, 3 in the morning when I was with a homeless person, when I was on the police department, it was in St. Elizabeth Hospital emergency room. My doctor is a St. Elizabeth physician. I've never had medical services anywhere in my life as an adult at St. Elizabeth Hospital. But I have some, but as you know, Mr. Counselor, I have serious disagreements with St. Elizabeth Hospital on this issue. Typical of the form, St. Elizabeth Hospital is professional. They brought in one of the most talented lawyers to represent them. and my good friend, and we go back a long, long way.
We
And
do.
and I want to acknowledge that.
Thank you.
And I don't know near as much on this issue as the professionals that you bring in. And I also enjoyed the presentation from the doctor and the Americans for Prosperity. I'm trying to learn. But my position today is pretty much the same it was on the first day, or probably the first week in I was office. I'm not even sure I was in office yet. St. Elizabeth was one of the first people I met with 14 years ago when I won that primary, and I sat in Garen's office. And I told him then, before anybody was talking about this, that I had big problems with our current certificate of need laws. And I think he would tell you that. So that is the spirit which I move forward in this conversation. I think it's a little bit unfortunate that we've gotten in this, at least in some corner, of kind of a confrontational role, because I don't look at look at it this way at all. I want what is best for our community. The difference between you and me is I don't work for St. Elizabeth Hospital. I work for the citizens of my district, and I'm trying to the best of my ability, as God gave me, to do the best I can for them.
Yes, sir.
And with that, I got one question. From past conversations, I got the impression we cherry picking or whatever we call this, but if another full service hospital was to could open up in northern Kentucky, I think that would take a change in the certificate of need laws right now. And I'm not talking about a surgery center. I'm not talking about a birthing center. I'm talking about a full service hospital like St. Elizabeth is now. Would St. Elizabeth be opposed to the changes in the laws for that to happen? The reason I'm confused about this is because when I've met on previous occasions, I've been told, well, another hospital wouldn't do that anyway because that's kind of a non-subject. It's not germane because they couldn't do it because they couldn't survive financially. So let's say it's a hypothetical and they wanted to and they were going to do it. Would St. Elizabeth be opposed to those changes in the law?
Can I give you a legislator's answer?
Well, I hope you give me
not a lawyer's answer.
Yeah,
I'd have to see the bill.
Like I said, they brought the best. But
no, I was going to
give me a John Schickel answer.
I'll give you a John Schickel answer, and I appreciate it. And you and I both, we love competition. I mean, that's the thing that is so hard to get your arms around. Everybody on this panel, we believe in competition. We're Americans, right? It's just, it's not a free market economy in the healthcare world, but that's a different point. If you look at this chart here, Senator Schickel, the concern is that if there were another acute care hospital that would come into northern Kentucky, look at how we're skewed. 75% we're picking up Medicaid, Medicare, and people who are self-pay but can't pay, right? So if you had another hospital that had that kind of a metric, then we wouldn't be as concerned. Now, there'd be other issues that we'd have to look at, but that's the primary problem we have right there. And these other four systems, who are the ones who maybe are most likely to come over, they're running away from Medicaid, Medicare, self-pay as quick as they can. So
it sounds like, so the answer to my question is yes, you would be opposed.
We would be open to considering anything, but I'm just suggesting that this particular slide is the big threshold problem we have with having someone else come in. Now, let me make sure I make this very clear. St. Elizabeth is not anti-competition. We compete every day in a greater Cincinnati healthcare market. We do it day in and day out, and we're number 2 in market share if you include Dearborn County. So Mercy Hospital, then us, then TriHealth. Take Dearborn out, we're number 3. So we are competing in a greater Cincinnati hospital. What we're opposed to is unfair competition. When somebody can come in and gobble up all the commercial.
But that's not what I'm talking about. I'm talking about another full-service hospital.
Well,
full-service hospital. That's my question, that hypothetical.
Yeah, and all these systems here are all full service. They offer the full panoply of services. That's how I define full service. You can be full service and still decide, well, we're not going to do all the Medicare, Medicaid, and self-pay. Now, if they show up in your ER, you have to, right? Your emergency room. But the concern would be that we're still left as the safety net hospital.
Mr. Chairman, may I have a follow-up?
One short one, please.
So, wouldn't they have all the same requirements that St. Elizabeth has now as far as a safety net hospital if they were a full-service hospital?
No, they would not. Now, they would with emergency medical transport and active labor, the EMTALA law. If a patient shows up in your emergency department, you have to care for them regardless of ability to pay. But they don't have. Look what Christ and Mercy and what they're doing over in Cincinnati. Mercy Health, TriHealth, take TriHealth. 32% of the Northern Kentuckians they're treating are Medicaid, Medicare, self-pay. They're half of what we're doing in the same market. So no, sir, there would not be that requirement.
Thank you.
We have time for two more short questions. First one will be Senator Meredith.
Thank you, Mr. Chair. Mine's really brief. And Mr. Guilfoyle, I appreciate your testimony and your expertise on certificate of need. Just want some clarification. You said that 43 counties in Kentucky do not have hospitals. This requires an opinion from you. Do you think that's because of the restrictiveness of certificate of need, or is it because it's just not financially viable for those communities to have a hospital?
The latter.
Thank you.
And finally, Senator Gibbons.
Very briefly, Mr. Chairman, thank you. Your early slide indicated that evolution to an integrated health system, and you talk about the merger with St. Luke. What was the year of that happening?
2008.
2008. And then, Mr. Guilfoyle, certainly enjoyed the presentation of both of you, but specific to you, you indicated that you had been on both sides of the CON process. You'd been on the side of the applicant and then on the side of the contesting entity. What's the proper term?
We call it an affected party is
Affected
allowed
party.
to request a hearing.
Just curious, draw back from this specific conversation, put on your hat that you saw me ask Dr. Guerin to put on a moment ago of helping us to make good policy decisions.
Yes, sir.
How many times have you been on each side? Give me a percentage ballpark.
Probably 50-50.
Great. Approximately how many times total have you been involved in CON hearings, contests? 10, 50, 30, 100, ballpark?
15 to 20.
It's a lot more than me because I've been involved in zero. So 15 to 20. So as you have been up front and in the middle of the mix, what would you suggest to us that we do differently to make this process work better for all citizens?
Well, that's a great question, and I appreciate the spirit in which it's asked. There's no question that the procedure, and I think Ms. Galvani with the Kentucky Hospital Association may have spoken to this when she testified. You know, as a practitioner of certificate of need law, there's probably some things where the process could be streamlined. I think that would really help the providers who are on either side, quite frankly. But, you know, I would have to say that the state health plan that we have that has the review criteria in it for all the various services that are covered, those are evaluated on a fairly regular basis. And the Kentucky Hospital Association is very good and very knowledgeable and very open to maybe we take something out altogether or maybe we relax the review criteria. I think that has to be a continual process. You know, Senator Meredith talked about when technology first comes online, it's very expensive. And you can make an argument that, geez, not everybody's got to have one of those, right? So certificate of need, it ought to be regulated. Over time, some diagnostic tools like a CAT scanner that Senator spoke to, that becomes almost like a stethoscope. So, then you look at how the medicine and the technology is evolving. And the hospitals in Kentucky, my client included, have always been ready, willing, and able to sit down and say, you know what, time has come for that to no longer be regulated. Or let's lower the standards for radiation therapy in the cancer world. Maybe that's antiquated. That's been on the books for 20 years. Let's fine-tune that. More than open to doing that. So I think the key is, and I would say this, Senator, that process has gone on under both Democrat and Republican administrations. Governor Steve Beshear did CON modernization toward the end of his administration. Governor Fletcher, Governor Bevin have been more than happy to, again, do rational modernization of CON. That's what St. Elizabeth has always been about, and we're going to continue with that.
So streamline the process and evolution of regulation, i.e. modernization, are two
Yes, sir.
ways you'd have us take.
Yes, sir.
Last quick question, because I'm always fascinated, especially with the Cincinnati Reds batting averages, but I'm curious about your batting average. Let's say that you've done a total of 20, 10 on the affected side, 10 on the applicant side. One loss. Give me an idea, ballpark.
Well, I'll just answer that for St. Elizabeth. And this will give you a feel for how it might be a little frustrating. We've only really had 3 certificate of need applications that I've been involved in. I spoke to 2 that we opposed, right? St. Luke Open Heart and Christ Hospital Ambulatory Surgery Center. We had a 3rd where we applied for a neonatal intensive care unit in northern Kentucky. We wanted to beef ours up. And we were opposed, believe it or not, by the University of Kentucky. I found a way to lose every one of those at the administrative hearing level, okay? And Ms. Fowles talked about a CON board in another state. Those are politicians. In Kentucky, we have a professional administrative hearing officers. They're pretty well immune to any political pressure. So I lost every one of them at the administrative hearings level with my partner, Matt Klein. But we were able to take it to the Franklin Circuit Court and ultimately get all 3 of those approved. When the one case approved, the other 2 were...
So if the Reds make it to the World Series, they need your help, but until they get there, they don't. That's what I'm hearing you say.
Senator, the Reds are not going to make it to the World Series.
Don't tell me that.
I think Hunter Green just proved that the other night.
Well,
yeah, Homer.
Okay.
That's what we're calling him up there. That's
well,
good.
thank you, Senator Gibbons. I want to thank all our presenters today. I think the information that has been presented has been very palatable. The task force is listening. I really want to, again, go over the jurisdiction that we as a task force have so that there are no misunderstandings out there. We simply say the task force shall review Kentucky's Certificate of Need program, including the state health program and related statutes. We will review the need for maintaining or modifying Certificate of Need for each health care service currently covered. We will submit findings and recommendations regarding the Certificate of Need to the Legislative Research Commission for referral to the appropriate committees of jurisdiction. And I will continue to try to trumpet that. With that being said, I do want to make sure that all the members have read the letter, which is a public comment letter that is in your folder from Dr. Thomas Strautman. I really do want you to review that and be aware of that. The next Certificate of Need Task Force meeting will be on September 18, and it will be chaired by my wonderful co-chair. And with that, I'm looking for a motion for adjournment. We have a motion. Do I have a second? This meeting is adjourned.